All right, wonderful. We've made it to the first hurdle of the first in-person meeting. So thank you again for all attending. This course, just to make sure we're all in the right room, is Should I Order a PET Scan? Integrating Molecular Imaging into Urologic Oncology Clinical Practice, Current Opportunities or Current Approaches and Future Opportunities. And just make sure this gets us to where we want to be. 5 course objectives today. I won't read them out to you, but you can see what they are. And then the pre- and post-test questions will be linked to these 5 objectives, which hopefully we'll cover in detail. And then just briefly to get started, you know, the whole idea of molecular imaging can be brought into a diagnostic algorithm, really for local staging, distant staging, and even bone staging in the diseases that we'll talk about today, including kidney, bladder, prostate, and testis. And, you know, most conventional imaging is part of standard of care guidelines, but essentially that bottom row there of molecular imaging can probably be moved up or incorporated into your algorithm in some form, and then our experts today will kind of go over the details of where that may fit into your clinical practice. So just briefly, introduction, Dr. Michael Gorin will start. He's an expert on molecular imaging for kidney, you can see here. I will touch base a little bit on molecular imaging in the use of bladder cancer. Dr. Rose from UNC is a new addition to this course this year. She's an expert on clinical trials and will be discussing molecular imaging in the setting of testis cancer. And then again, Tom Hope from UCSF will be just touching base on molecular imaging, PSMA for prostate cancer staging. So with that, we're a couple minutes behind and we'll get started. And I think Dr. Gorin, I'll just scoot out of the way. Oh, actually, why don't we load your, yeah.
So you load it from here, but it'll play from there?
Actually, you have to load it from here.
Oh, boy.
And
with that mouse, with your right mouse.
Okay.
if you were actually on that screen.
Yeah, I don't know. They had mine in, oh, wow. And this monitor has like a weird refresh thing going on. I'm going to have a seizure giving this talk. Okay. Okay, good morning, everyone. Thank you very much, Mark, for the invitation to present at this year's course. I guess this is like the 3rd or 4th year we've been doing this now. It's amazing how much the content and the slides change every year. When we first started, PSMA imaging wasn't even approved yet, right? And now it's like in every guideline, so it's pretty remarkable. So this morning I'm going to be talking about risk stratification of localized renal tumors using molecular imaging. This is a topic where is sort of more conceptual than it is actually used in clinical practice. Probably the main imaging agent is in clinical trials right now, has not yet been approved, but I think probably by the meeting this time next year, we'll be, just like PSMA, we'll be talking about an agent that's clinically used. So this is really just a primer into some of the concepts that I think we're going to see in the future to come. And also, this talk is focused on localized renal tumor imaging. There's a whole other talk that could be given on molecular imaging of metastatic kidney cancer, but this is really just going to focus on localized renal tumors. So these are my disclosures. Probably most relevant to today's talk is that I am a co-inventor on several diagnostic imaging agents targeting carbonic anhydrase 9, which is one of the molecules that we'll be discussing this morning. So, as probably everyone in the audience is aware, renal tumors come in a variety of different histologies, and when one is faced with a renal mass, often it's indeterminate and the histology isn't known. The histology could be anywhere from cancerous to benign, the most common cancerous histology being clear cell renal cell carcinoma. Excuse me. The most common histology being clear cell renal cell carcinoma, and the most common benign histology being oncocytoma. And this matters because benign renal tumors don't require treatment at all, whereas renal cell carcinomas typically do, some being more indolent than others, and some you could get away with surveillance and ablation, where others really need to do extirpative surgery. And so when we look at the prognosis of the various renal tumor histologies, we know that it's quite variable. There are some renal tumor histologies where there's essentially perfect survival, even as far out as a decade after diagnosis, whereas others, 20-30% of patients will have metastatic disease. And so being able to take a renal mass that's uncharacterized on the basis of imaging to know its histology and then tailor treatment is critical. And if we look at guidelines from the National Comprehensive Cancer Network or the American Urological Association, they reflect a myriad of different management options, which are all predicated on the aggressiveness of disease. And so if we look at the management here of just the stage 1 or the small renal mass per se, less than 7 centimeters, or I'm sorry, less than 4 centimeters, the treatment options are quite varied, or rather the management options are quite varied. They range everything from partial nephrectomy to surveillance where you do nothing at all to removal of the entire kidney. And what the guidelines state is that you should really evaluate the underlying histology of the patient's tumor to decide on which of these management strategies is most appropriate. And the guidelines actually state that biopsy of small lesions may be considered to obtain or confirm a diagnosis of malignancy and to guide surveillance or ablative techniques. There are, however, limitations to renal mass biopsy. There are 2 systematic reviews or meta-analyses in the literature, which really take us through and serve as sort of our textbook on renal mass biopsy. And what we know is that the non-diagnostic rate of renal mass biopsy is somewhere in the range of 10 to 20%. Thank you so much. Is somewhere in the range of 10 to 20%. And so roughly 1 in 5 patients who undergo this procedure, we will not be able to yield the information which we seek. In addition to that, there's a major complication rate of approximately 1%. Simply not all tumors are biopsyable due to their anatomic location. And so while it's great that in concept that we could characterize the underlying histology of renal tumors to guide management, in many patients this simply is not possible. So the question becomes, can we use something like molecular imaging to help us differentiate and characterize renal tumors so we can know the underlying histology to make management decisions? So what I'm going to show you over the next probably about 15 minutes is that, in fact, we can. And the real starting point for this is targeting what's known as carbonic anhydrase 9. So CA9 is a cell surface protein that's overexpressed in cases of clear cell renal cell carcinoma. Under normoxic conditions, CA9 isn't expressed. However, when cells face the stress of being in hypoxia, they'll overexpress CA9 to help buffer the acidic interstitium. This process is modulated by HIF-1 alpha. And so as we know from the work of Marston Linehan and others, that renal cell carcinoma is clear cell renal cell carcinoma, a ubiquitous event in the pathogenesis of this tumor is loss of the then Hippo-Lindau gene, which is responsible for ubiquitinating HIF-1 alpha. So upon loss of VHL, you get upregulation of HIF-1 alpha, and then upregulation of CA9. So CA9 is overexpressed in roughly 95% of all cases of clear cell renal cell carcinoma. It's really not expressed to any meaningful extent in other renal tumor histologies. And you can see here what it looks like under the microscope. When you stain for CA9, you can see it's beautifully expressed all over the surface of clear cell RCC, but not in this case, papillary RCC. So this serves as an opportunity to target this molecule using molecular imaging to help pick out tumors that are the clear cell histology, which is the most, or not the most aggressive, but the most common aggressive form of kidney cancer relative to all other histologies of indeterminate renal masses. So this has been done using an antibody known as girentuximab. Through the years, girentuximab has been labeled with many different radionuclides. In 2013, it was labeled with I-124 in the REDECT trial. And what this allowed to be done is PET-CT imaging to help pick out clear cell RCCs versus other renal tumor histologies. And what I show here is a picture of a clear cell RCC, which beautifully lights up with the radiotracer, whereas a benign oncocytoma does not. So this trial was published in 2013 in the Journal of Clinical Oncology. And the trial design was such that patients who had a small renal mass were imaged with conventional multi-phase imaging as well as PET-CT prior to either partial or radical nephrectomy. And then the histology then served as the truth standard to which the PET-CT results were compared, and this allowed for calculation of all the standard diagnostic parameters. And so when we look at just contrast-enhanced imaging, the sensitivity for picking out clear cell RCC apart from other renal tumor histologies was roughly 76%. However, once PET-CT was employed, this number went up to 86%. More impressively, however, the specificity of contrast-enhanced CT was only around 50%, and this number went up to 86% upon implementation of the PET-CT, giving a positive predictive value of 69% and negative predictive value of 94% for PET-CT versus significantly lower values with contrast-enhanced CT. So despite these very, very encouraging results, which were presented to the FDA, it wasn't quite approved at that point, and the FDA asked for a confirmatory trial. Unfortunately, the company that owned the compound at the time, known as Wilex Pharmaceuticals out of Germany, Wilex Pharmaceuticals, they ran out of cash, and this compound got placed on the shelf. That was until recently when Tilex Pharma out of Australia in 2017 actually purchased the IP around this antibody. They went ahead and have relabeled it now with zirconium-89, and they're putting it through its paces in what's known as the Zircon trial, which I learned last night is like 99% accrued. And so this trial is going to report out soon, and will probably confirm the findings of the REDECT trial, and then will be put forth to the FDA as a new drug application. And I imagine by this time next year, we will probably start seeing the first patients dosed with this imaging agent, and so it should hopefully make a big difference when managing patients with an indeterminate renal mass, where, as before, we either could not characterize their histology or we relied on biopsy, which has significant limitations, and now we could do a simple molecular imaging test to discern whether or not it's clear cell. There are, though, as enthusiastic as I am about girentuximab PET, there are some significant limitations to this imaging agent that are worthy of note. And the first is that it's an antibody-based radiotracer, which has a very long circulating time. Now, there are some reasons why this could potentially be a good thing, but simply from a radiology workflow standpoint, patient sort of experience standpoint, this poses an issue, because you have to actually inject the patient with the radiotracer, wait several days, and bring him back for imaging, which is very different from what we currently do when we do, say, an FDG PET scan, where we inject a patient and put them on the scanner about an hour later. There's a high cost associated with just PET technology in general, and yes, here in the United States we have great access to it, but in many parts of the world they simply do not have access to PET or can't afford to use it. There are issues also with the availability of a distribution network, which is required to manufacture and radiolabel and distribute antibody-based pharmaceuticals. Once approved, this agent will be on patent for another 10 years or so. So this is going to be a very expensive technology to be able to use for our patients. And probably the most significant issue is the fact that it only tells you clear cell RCC versus all other tumor histologies. And yes, while clear cell RCC is the most common of the aggressive forms of kidney cancer, knowing RCC versus all other histologies, when all other histologies includes both benign and some indolent, but also some aggressive forms of kidney cancer, may not always be the most helpful. So the question then that my group asked is, can we use molecular imaging to differentiate among renal tumor histologies, but can we address some of the issues that exist with using antibody-based girentuximab PET-CT? So we have explored this question through the use of not a PET imaging test, but a SPECT imaging test. And so we focused on asking ourselves, what is different about these two tumors? Clear cell RCC being the most common form of kidney cancer, and oncocytoma being the most common benign renal mass. And what it comes down to, the difference between those renal tumors, is the presence of mitochondria. So if we look at the oncocytoma under electron microscopy, we see images like this, where because of mutations in in genes responsible for mitochondrial respiration, we see that they're absolutely jam-packed full of mitochondria, and that's actually why under the microscope these tumors look so different on H&E staining. The oncocytomas are very eosinophilic or oncocytic, and that's because of the presence of all these cellular organelles, whereas clear cell RCC is clear under the microscope because it basically just contains glycogen vacuoles. So in the electron micrograph, a clear cell RCC looks like this, completely devoid of this organelle. So we asked the question, can we use a mitochondrial imaging agent to be able to distinguish between these two? And it turns out that there are quite a number of quite a number of mitochondrial imaging agents that are available, both for clinical use and for investigation only, that we could potentially use for this application. We were though trying to solve some of those limitations of germtuxin PET, which included cost and availability. So the choice for us was obvious, to use a radiotracer known as Sestamibi, which has been clinically available now for probably 30 years, if not more, and could be used with SPECT imaging, which is more ubiquitous and lower cost than PET. So this is what Sestamibi looks like. It's a lipophilic cation. It finds its way into cells by passive diffusion, and then once within the cells, it goes into the mitochondria, where then it becomes charge trapped due to the membrane, the difference in membrane potential within the mitochondria. So any cell that has a large number of mitochondria should take up Sestamibi. Now, interestingly, Sestamibi's mechanism of elimination from the cell is by way of the multi-drug resistance pumps, with the so-called MDRs. And at the time, when we were first postulating using Sestamibi for this application, what we excitedly learned is that renal cell carcinoma, one of the reasons why we don't use cytotoxic chemotherapy for this tumor is because it has large numbers of multi-drug resistance pumps. So the very mechanism that Sestamibi is eliminated by the cells is actually upregulated in the tumor that we hoped would not take up the radiotracer. So actually the mechanism was really making a lot of sense to us, at least in theory, which it did pan out. So what is Sestamibi used for clinically? At least most commonly, and that's probably for parathyroid imaging. So parathyroid adenomas contain oxophilic cells. These oxophilic cells, just like oncocytomas, are jam-packed with mitochondria, and our colleagues in endocrine surgery use this test to help localize parathyroid adenomas. It also has an indication for imaging breast tumors, and it's also very commonly used for myocardial nuclear stress testing of the heart. So we looked in the literature to see if anyone had ever thought of this concept before, and it turns out there was one case report where someone had administered Sestamibi to successfully image an oncocytoma. This was done in the 90s, though, with planar SPECT imaging. So we thought that we were perhaps onto something, especially given the mechanism, but we really had to test this going forward using modern molecular imaging tools. So we did this initial study in 2015 where we imaged six patients, 3 with oncocytomas and 3 with renal cell carcinomas, and then looked to see whether or not this molecular imaging agent could be taken up by the tumors. These are the results from the first 6 patients that we imaged here. You could see the Sestamibi radiotracer is it's hard to point when you're parallel to the screen like this. The Sestamibi radiotracer is nicely taken up in the renal tumors, as well as in normal renal parenchyma, and this is in sharp contrast to what we see with renal cell carcinomas, where you see no uptake of the radiotracer and probably elimination of the radiotracer by the MDR mechanism that I had talked about earlier. And so we felt that we were onto something here with being able to differentiate between the renal tumor types. We then went on to do a more robust diagnostic trial where we took 50 patients who were scheduled to undergo either partial or radical nephrectomy. We imaged them with Sestamibi SPECT CT prior to surgery, and then just like in the REDECT trial, we had the histology as the truth standard. And what we found is a sensitivity of 87.5% for being able to pick out oncocytomas and hybrid oncocytic chromophobe tumors, which are basically a cousin of oncocytomas, very, very closely related molecularly, but under the microscope maybe have some features that make them look like an indolent form of kidney cancer. And On the flip side, for looking at RCCs plus angiomyolipomas, we only had 2 false positive tumors. So pretty exciting result for an imaging test that, is widely available, very, very cheap, it's generic, and so forth, to be able to overcome some of those limitations of using PET-CT imaging for this application. So since the time of publishing our first study, this work has been confirmed by a number of other groups. Just in the interest of time, I won't go through those individual studies like I have here on this slide, and I'll skip ahead to sort of a summary that was recently published in European Urology, summarizing all the confirmatory work that's been done. And what we see is, sensitivities. They range quite widely in the literature. Anywhere from 2/3 to 90% of tumors, oncocytic tumors, could be picked up using the radio tracer, but the specificity of the imaging test is exceptionally high. And what we know is that the negative predictive value of the imaging test for ruling out a benign renal mass is consistently north of 90% in all the studies to date. So I believe there's an evolving diagnostic approach that we're going to see with imaging renal tumors. If you want, this could be achieved today using a cheap imaging agent like Cestamebe. Alternatively, we will have the girentuximab imaging agent likely in the next year to 2 years. And with those imaging agents in hand, you could modify currently how you're taking care of patients, where the current paradigm in most urology practices, small renal mass equates to surgery. Some of us are attempting to use biopsy with all those limitations, where we're trying to select patients for surveillance versus ablation versus intervention. But I think what we're going to see is to be able to do something more like this, what I show on the slide, where you could really tailor the approach, management of a small renal tumor, to the histology that the patient has, using molecular imaging to help you differentiate between the different histologies. And this is just the framework that I use in my practice using Cestamebe, where, if a patient has a very short life expectancy, it doesn't really matter what their tumor histology is. Less than 10 years to live, we could watch a clear cell RCC. If a patient, is very, very young, even if it's a benign renal mass, we're not going to watch it for, 20 years and so forth. But really, for your average patient, someone in the life expectancy range of 10 to 20 years, where it really makes a difference to know what their histology is, I start by performing a Cestamebe SPECT CT. If it's a hot tumor, I then perform a renal mass biopsy to confirm that the diagnosis is indeed a benign renal tumor. And if it in fact comes back as an oncocytic neoplasm, I then place those patients on surveillance. If it comes back as an RCC or it's cold in the Cestamebe SPECT CT, then we move towards intervention, and I try to tailor the approach of ablation versus surgery for that patient based on sort of their wishes and my goals for the patient with respect to renal preservation. So in conclusion, the T1 renal mass, or the indeterminate renal mass, is a diverse clinical entity which includes a number of benign and malignant tumor histologies. Patients presenting with one of these tumors should ideally be managed with a risk-adapted approach. Renal mass biopsy could aid with this purpose. However, there are significant limitations to this to this diagnostic procedure. Molecular imaging offers the promise of a non-invasive means of helping us determine these histologies. And currently, we have one available imaging test and another on the way to help us achieve this, and that is Cestamebe for picking out oncocytomas and oncocytic benign renal tumors, and girentuximab, zirconium-89 labeled girentuximab, for helping to pick out clear cell RCC. So with that, I'd like to say thank you. Thank you to the American Urological Association for allowing us to give this course. Thank you to Mark for organizing it. I don't know, Mark, do we have time for questions now, or do we wait till the end?
Yeah, maybe since we started a little bit late, we'll hold the questions to the end, if that's okay, and we'll keep moving. And then any update on the... Okay. Yeah, would that be okay? And then, do I load those up? So these will be the presentation test questions that I spoke about earlier. If we could have you log on to your app and then answer these. And then we'll continue. Curiosity is working for those of you who have either logged on or text the link or the number. May I try as well? Worked for me. You've joined the AUA meeting session. All right. All right, so test question number 1. What do you love most about New Orleans? How do I go to the next question? I click above this on the gray bar. Is that correct? All right, pre-test question number 1. Which of the following is correct about 18F, DCF PYL, and 68 GA PSMA 11? I'm following along here. Once I text my answer, we can just go on to the next one. I'm going to keep moving just in terms of time. Thoughts on how I can get this to the next question? Question number 2, which radiotissue for bladder cancer staging pools in the urinary tract and therefore may mask tumors in the bladder? A, B, C, or D, FDG, choline, acetate, or methionine? And I think if I click, we'll go on to test question number 3. Pre-question number 3, which protein is highly expressed by clear cell renal cell carcinoma but not other renal tumor types and serves as a target for molecular imaging of this malignancy? A, B, C, D, or E? Going to move on to question 4. 99 technetium sestamibi localizes to which cellular organelle? And then we can go on to the last question. Which setting is most appropriate to order an FDG PET scan? ABCD in terms of testis cancer. All right, maybe we'll keep moving. I can step out of this one. we're in this.
2 over the Chrome. And there you go. And then click on yours. I think that's going to work.
All right, wonderful. We're getting there again. So we'll switch gears a little bit and get started on bladder cancer, financial disclosures and conflicts of interest here. And then in terms of what we're going to talk about in this brief presentation, we'll talk a little bit about the radio tracers itself used in bladder cancer, some assessment of the original or the primary tumor, as well as lymph node and bone metastases. We'll take a little bit of time to discuss what are the responses to neoadjuvant chemotherapy and immunotherapy and how we can assess those. And lastly, we'll wrap up looking at the imaging guidelines. So which radio tracer do we use and why in terms of bladder cancer? You know, an FDG is widely available. It has a high sensitivity for osteolytic lesions, but it often will have some false negatives in terming osteoblastic lesions. And it pools in the bladder, making it very difficult to assess any primary tumor of the actual bladder itself. Alternatively, choline and acetate are radio tracers that you can consider using, but one of the limitations is its short half-life, which requires an on-site cyclotron. And of note, acetate negatively impacts its performance in patients who have had prior BCG. So looking at bone imaging, typically the 2 most common radio tracers are technetium 99 and sodium fluoride. Technetium 99 is widely available. It's cheap, but the spatial resolution is fairly poor. Sodium fluoride, on the other hand, detects both osteoblastic and osteolytic lesions and has much better spatial resolution, and we'll get to these a little bit further on in the presentation. So to start off, when we look at primary tumor staging, you can see here on the image on the left, this is the actual pooling of FDG that we're talking about. It really obscures the entire bladder, and it's difficult to assess the tumor itself. The image on the right is a contrasted CAT scan, and you can see the large tumor on the left lateral wall. It is clearly seen, highlighting the limited utility in FDG radiotracer PET in primary tumor staging. There has been a number of techniques investigated in order to increase the performance characteristics of primary tumor staging to use FDG PET for the bladder itself, and you can see some of them here. After patients have their TURBT, they're reassessed for residual disease, and patients who get an FDG PET, you can have them drink a fair amount of water, a half a liter, and then void. You can give them forced diuresis, either through oral or IV Lasix, again, to try to flush out that radio tracer in the bladder, or you can actually insert a catheter, retrograde fill, and then empty their bladder to get a better view of the tumor that may be residual. And here's some demonstrations on when that occurs. This is a bladder tumor, the standard FDG PET, and you can't see really any tumor in the bladder itself, but in patients who get a fair amount of water to drink, 60 milligrams of Lasix, a little bit of time, they'll excrete all that radio tracer, and lo and behold, you can see that residual bladder mass. And again, even in patients who have neoadjuvant chemotherapy, the same theory applies. This is the patient, again, after chemotherapy to assess residual bladder tumor. Can't see much on the FDG PET of the bladder, but after the protocol of hydration, Lasix, and urination, you can make out the residual tumor that may ultimately change our management. So this is an interesting prospective study to actually assess this, and Yan and colleagues looked at 79 patients with bladder cancer who got the standard FDG PET, and they got a PET with a delayed diuretic to enhance that assessment of the bladder itself. This was all done within 30 days of their original TURBT, and then after their PET, within 2 weeks, they got a repeat TURBT to see what the residual disease was. Was that actually benign inflammatory process, or was that malignancy? And what they found in doing this is they could assess the standard uptake value of the PET to allow for a risk stratification. Not only the uptake mean, but also the maximum and the bladder wall thickness allowed for a risk stratification scheme that they could counsel patients on. And those with high risk, clearly you need repeat resection. Lower risk patients may be able to avoid repeat TUR. So this is kind of a busy slide, but just highlights that all the studies that have used PET CT for primary tumor staging, you can see a wide use of FDG and choline as well as acetate, different reference standards in terms of pathology. All of this leads to a wide sensitivity, specificity, and predictive value when using FDG or using PET radio tracers for primary bladder staging. So just to switch gears for 1 second, even though MRI is not a molecular imaging tool, it has been used widely for primary bladder cancer staging given the new VIRAD scoring system. And the VIRAD scoring system is similar to that of PIRADS, where scores 1 and 2 are essentially low risk for muscle-invasive T2 disease. Score 3 is equivocal, and score 4 or 5 are at higher risk for T2 staging. And this imaging modality has been widely validated across the entire world with good performance characteristics in terms of local bladder cancer staging. So that leads us to our next imaging topic of that of lymph node and bone. We want to assess both regional disease and metastatic disease in the setting of bladder cancer. And conventional CT, which is endorsed by guidelines, sometimes has sensitivity specificities quite low and accuracy somewhere around 50% to determine whether a lymph node is actually positive or not. So this may be an area where PET imaging can enhance our performance characteristics. There's been a number of meta-analyses that have compared the sensitivity and specificity of CT, MRI, and then PET CT, namely FDG PET, in determining lymph node staging in bladder cancer. Some of the heterogeneity of the actual studies included in meta-analyses drive these differences, and that there's different cutoffs used for what's actually a suspicious lymph node, in lymph nodes that are avid, where they actually biopsied or resected to confirm pathology. But generally speaking here, you can see similar sensitivity and specificity when you compare CT, MR, and PET in terms of lymph node staging for bladder cancer. Again, busy slide, but you can see all the studies that have been done in terms of lymph node staging, and there's a wide scope of imaging modalities and radio tracers. The populations are actually quite small, somewhere between 5 and maybe upper 90s in patients, different reference standards, and again, this leads to a wide scope in sensitivity, specificity, and predictive value when using FDG PET for lymph node staging. So this brings up the question, is there a added benefit to lymph node assessment using PET imaging rather than CT alone? And this was a nicely done prospective study of 100 patients that were high-risk muscle-invasive bladder cancer who were all fit for cystectomy. These patients received CT as well as a CT PET with FDG, and then the authors looked at, well, did the FDG PET actually change our management? And you can see here it did. It showed metastatic disease in 47% of patients that were not seen on contrast imaging alone. This altered treatment in over 25% of patients. Cystectomy was aborted or canceled in 16. The extent of neoadjuvant chemotherapy was made longer in 12 patients, but this did come at the risk of some delayed treatment or false positives, but that was in only about 3 of the 103 patients. So hinting there may be some utility in getting an FDG PET CT either in combination or in place of contrasted CT alone. Perhaps the largest retrospective study in the literature just came out the other year by a German group, and they looked at 711 patients who also had the same kind of study design, and that all patients received a contrasted CT plus a FDG PET CT. And you can see here the clinical stage changed in 25% of patients. As you can imagine, the vast majority of those were upstaged, given the performance characteristics of PET to determine lymph nodes. And then on the lower right here, you can see that overall, 16% of patients' treatment was changed based on the PET. Local treatment changed in 20, neoadjuvant chemo changed in 13, and then palliative care treatment changed in 8%. Begs the question, should we be doing PET with MRI, since MRI has a higher performance characteristics for soft tissue? A couple of small studies have done, looked at this. Essentially, the lymph node yield in terms of the cystectomy drove the sensitivity, and take-home message, this appears similar to CT and FDG PET. So do a handful of institutional studies change management? No, but there's this wonderful group in Canada who's doing a large multi-center prospective trial on this topic. Each year I email them for an update in preparation for this course, and they sent me back that they've completed recruitment and they'll have 2-year follow-up. So a couple more years, and they'll be able to tell us hopefully a little bit more certainty whether FDG is indicated. So other radiotracers, just briefly, choline and acetate are radiotracers we can use to stage bladder cancer. However, they don't pool in the urinary system. They're rather physiologic in the pancreas, spleen, and liver, so they don't obscure the primary tumor like FDG PET. A large meta-analysis looked at the performance characteristics of acetate and choline PET. I mean, you can see their sensitivity, somewhere around 66%, specificity high around 89%, but the take-home message is this is similar to the performance characteristics of contrasted CT, MRI, and FDG PET. So really the next question, can we use this imaging modality to assess response to neoadjuvant chemotherapy? Small study of 19 patients did this. They used FDG PET, which I correctly identified responders in 95% of the patients in this study. They could differentiate complete responders from incomplete in about 68%, and you can see sensitivity and specificity listed here, which was somewhat comparable to contrasted CT. Is there ways that we can check for a response to neoadjuvant chemotherapy before the actual chemotherapy is completed? This was a prospective study that adopted FDG PET after the first 2 cycles of chemotherapy. So patients would get an upfront PET, get 2 cycles of chemotherapy, and then subsequent PET. They assessed the response based on a 50% standard uptake value, and this would determine whether the patients were T2 or no longer T2. And ultimately, the take-home message is that those patients that responded would go on and get completion chemotherapy with the hopes of a complete response. Those patients that don't respond could go straight to cystectomy, so potentially impacts our management. Looking at bone, this is really brief that technetium-99 is widespread adopted and used. You can see on the left 2 images that the performance characteristics are somewhat limited, and you can see the entire axial skeleton has uptake. The sodium fluoride on the left can pick up a specific bone lesion, but in 2015, CMS decided that sodium fluoride PET is neither reasonable nor needed in terms of staging bladder cancer, and has fell out of favor. So lastly, how do we determine whether patients are responding to immunotherapy? Can PET be used for that? Really, our approach is that we're trying to do this as imperfect as they stand, because we'd like to identify patients who don't derive any clinical benefit from immunotherapy, and they could avoid being exposed to the adverse events if we could determine whether they were responding or not. And really, it's important to identify responders as early as possible, again, so we can avoid the toxicity or allow a different line of treatment. And in that vein, this was an interesting, well-done Nature study in 2018 that looked at zirconium linked to atezolizumab. And the take-home message is really that the standard uptake value corresponds fairly nicely with disease burden in addition to disease response. So it looks like coming down the pipeline in the future, we could start to assess for immunotherapy response depending on what evolving radiotracers we come up with. So just to wrap up, in terms of guidelines, both the NCCN and the American College of Radiology makes it very clear that there is no role for PET imaging in non-muscle invasive bladder cancer. In terms of muscle invasive bladder cancer, their guidelines are a little bit fuzzy. In the pre-treatment space, they say it may be useful in patients who have what we suspect is greater than T2 disease, and it may change management in those with greater than T3 disease. As we've shown, it may improve sensitivity for nodal and metastatic disease, and there appears to be increasing data in this space. In those patients who have already been treated, there may be some utility if they didn't already get imaged pre-treatment, and it may be used to resolve some equivocal findings on other tests. So to wrap up, there is increasing evidence that supports the use of FDG PET in staging of muscle invasive bladder cancer. There is no role for it in non-muscle invasive bladder cancer, and really the guidelines endorse select use, so we have to use this judiciously, and then the future of radiotracers may determine whether they can help assess neoadjuvant chemotherapy response and response to immunotherapy. So with that, I'll hold here and pass off to Dr. Rose. I think you can scroll down.
Yeah, okay. Great job, Mark.
I tried to speed up.
No, yeah, I was going to swap because that had to be the call. Would you walk us back on track?
All right, great. Thank you so much. And I'm going to be talking about the use of PET in the diagnosis and management of testis cancer today, which is a new addition, I think, to this course. And hasn't changed all that much in the last few decades, although there's some really novel things going on in recent clinical trials and upcoming stuff that we'll talk about. But I'm going to go through staging, then evaluation of post-chemotherapy residual disease, which is really the meat of use of PET in testis cancer, and then talking about prediction of early treatment response, a little bit similar to some of the stuff we just saw in bladder cancer, and then a comment on some novel tracers and future directions. So to start out, the bottom line here is that both seminoma and non-seminoma, pretty on all guidelines, the use of PET-CT for initial staging is not recommended and is particularly recommended against. And there's actually a number of different sort of small studies looking at the sensitivity and specificity of PET in the different types of testis cancer. And this is one of the larger studies. And I'll just make the comment that all of the studies pretty much that have been done have been using FDG as the tracer. So this study it's a big German study, looked at 72 patients, and all of these patients were undergoing primary RPLND for either a stage 1 or stage 2 non-seminomatous germ cell tumor. And so they all had PET prior to surgery. And so the gold standard here was pathologic viable tumor. And they initially had set out to accrue 169 patients, and kind of while this study was going on, we really started to do more and more active surveillance for the stage 1 patients, and so less and less patients were having primary surgery, and they didn't meet their accrual goal. And out of the 72 patients that did end up accruing, 19 of them, so 26%, had pathologic nodal involvement. And so they set out, we know that at baseline, CT misses sort of 20 to 30% of lymph node involvement, and also, 20 to 30% of patients are actually downstaged at the time of surgery. And so they set out with a baseline negative predictive value of CT of about 70%, and set out to increase it with PET to 90%. So that's how they did their stats. And their primary endpoint of negative predictive value ended up being 78%. So was a negative study overall. But if you actually break it down and look at sort of the sensitivity, specificity, accuracy, it's actually kind of similar to what we just heard in bladder, is that it does slightly increase some of these metrics, but really slightly. And when you take into account the difficulty in interpretation and the access and the cost, et cetera, it's really not a benefit and probably not cost effective to do PET-CTs for staging. But you can see here, they increased negative predictive value from 67 to 78% with CT and PET. We use PET more often in the post-chemotherapy setting for seminoma, and so one might ask, has there been a similar sort of large prospective study in seminoma staging? And the answer is really no. The largest study that was done was actually, done over 100 patients, but actually looked at patients throughout the course of their disease. And if you look at just the seminoma patients, which was only about 40% of the study, and then those are in initial staging, it only ended up being 16 patients in the big study. So I didn't even include it kind of in the slides because we don't have sort of quite the same data, but from most of the single-arm studies, the retrospective things, seminoma looks similarly, like there's a very small, perhaps, improvement in initial staging, but very similar to contrast-enhanced CT, which remains the standard of care. I will say, in light of the fact that my institution doesn't have very much IV contrast right now, if you're staging sort of new testis cancer patients and you don't have IV contrast, it would not be unreasonable to get a PET-CT to help stage, although it's clearly not standard of care, and I don't know about insurance reimbursement. But for in general, contrast-enhanced CT remains standard for staging of both seminoma and non-seminoma patients. Now, once we get into post-chemotherapy residual disease assessment, it's a very different conversation because we do use PET-CT sometimes in this setting. So we know from multiple prior studies that size of mass in seminoma is very predictive of whether or not there's viable disease left. So these are just 3 studies, but there's actually many more than this, that shows that this cut point, this magical cut point of 3 centimeters ends up being really important. So these are seminoma patients with post-chemotherapy, who have received primary chemotherapy and have residual masses less than 3 centimeters, the rate of having viable seminoma in one of those is less than 10% in almost all the studies, and you can see these 3 here it's actually 0. Greater than 3 centimeters, though, it's variably reported, but it's tends to be between 10 and 50%, probably somewhere in between. And CT really just ends up doing a poor job telling us which of those patients have viable seminoma or not. And so based on these studies, if you have a patient who's received chemotherapy and has a mass less than 3 centimeters, a PET-CT is really not indicated because the chance of any residual seminoma is so low that the likelihood of false positive ends up being much higher, especially with what we know about seminoma. And so we use FDG avidity in this setting, so in the tumors that are greater than 3 centimeters, as our best predictor of post-chemotherapy residual seminoma right now. I will say, as more and more data comes out on sort of mRNAs and things like that, I'm hopeful that this will no longer be our best predictor of post-chemotherapy residual seminoma that we use in clinical practice in the future, because the desmoplastic and inflammatory reactions we see with seminomas actually leads to false positive FDG avidity very commonly, and it's very hard to interpret these scans. As many people in the room know better than I, since I'm a medical oncologist, these are really demanding, hard surgeries. The complication rates we see in some of the post-chemotherapy seminoma patients are quite high, and in some of the bigger studies, around 20% of sort of chylosociety, retrograde ejaculation, hematoma, et cetera, et cetera. So these can be challenging, long surgeries. So the actual incidence of patients that need surgery for seminoma after chemotherapy is and should be quite low. And this should really only be considered at these high volume centers with surgeons that have a whole lot of experience, because they end up being really difficult surgeries, and the decision on whether to take them to surgery or not based on a PET scan can be really challenging. And so the reason we do this really comes out of this relatively small study called SEMPET, in which 51 patients with advanced seminoma had post-chemotherapy FDG PET scans. And you can see here that the PET-CT performed pretty well. And so out of these patients, the FDG PET had 100% specificity, 80% sensitivity with 100% positive predictive value. I mean, those are pretty good numbers. Whereas you can see conventional CT, even if you draw that size criteria, had only a positive predictive value of 37%. And so really size of mass does not predict viable seminoma. And so based on this, this is really where a lot of the guidelines came from, to get a PET scan in patients with residual masses greater than 3 centimeters after chemotherapy. Now, also out of the SEMPET study, it looked like waiting longer after chemotherapy was better. And so they sort of prospectively got this cutoff of waiting at least 6 weeks after you stop chemotherapy. And then there's been larger studies that actually validated this time frame. This is another really important point about using PET in the post-chemotherapy seminoma study. So this study looked back at 127 patients who had PET scans from 19 different centers in Europe. All of these studies are from Europe. They're much better at studying testis cancer than we are. And out of them, only 26% of patients had positive PET scans. But really, both positive predictive value and negative predictive value went up very well, a lot in the after 6-week time frame. And I just want to point out, as a medical oncologist, that this 6-week number is actually not after the last cycle starts, but after the last dose of chemotherapy. So it actually ends up being like day 63 after we count it as cycle 4, day 1. So it's a good few months there to wait after people finish chemotherapy to consider getting a PET scan. But you can see, even in this cohort of patients, the negative predictive value of PET after 6 weeks in lesions greater than 3 centimeters ended up being in the 90s, so it looked pretty good. And so after sort of all these papers came out, this really went into the guidelines as patients post-chemotherapy with seminoma should undergo a PET scan. If positive, consider surgery. If negative, surveillance. And then this paper came out a couple years ago, which actually put some of this into question. It's a pretty large for the conversation study, looking at patients that had a positive PET scan post-chemotherapy. So all the patients included had a positive PET scan. And then they looked at, what happened to these patients, how often did they relapse, how often did they have viable seminoma, et cetera, et cetera. And interestingly, so it ended up that 23% of these patients ended up having either like seminoma in the specimen or ended up relapsing, and that's a pretty low number. So out of all the patients that had a positive PET for seminomas greater than 3 centimeters, only 23%, so positive predictive value of 23% for having viable seminoma. And all the things that we typically look at, time from chemo, SUV max, size of residual mass, whether the radiologist or nuclear medicine doctor thought it was equivocal or not equivocal, didn't seem to matter in this study. And the other important thing to note is out of all the patients that relapsed, the ones that had surgery or didn't, or the ones that had persistent PET positivity, because a lot of these patients actually didn't go to primary surgery, all but one were actually cured with salvage chemotherapy. And so if you actually look at the numbers, out of the 90 patients that ended up being included, 51 of them, so more than half of them, ended up going on for repeat imaging instead of initial resection. And out of those 51, you had 11 end up relapsing and 2 going after a second positive scan to surgery and having seminoma in the specimen. And so those are still not, that's still a minority of patients. So even those who had persistent PET positivity on their scans, on serial scans, a minority of patients actually had viable seminoma or relapse. And so even if you have persistent PET positivity, it doesn't mean that you necessarily have viable seminoma. So it gets very complicated in the setting of these being really challenging surgeries. And so it's a little bit up in the air who we should take to surgery and when, and really if all patients with PET positive tumors greater than 3 centimeters actually need surgery or not. And so if you look at the current version of NCCN guidelines for patients with seminoma after chemotherapy and a residual mass greater than 3 centimeters, it says surveillance or PET. So it's really a choice and a discussion. And then, if you choose to do the PET scan and it's sort of indeterminate, consider a repeat. They recommend 6 to 8 weeks. I typically will do it a little bit longer. And then if positive, consider resection or biopsy. In that study I just showed you, a few patients got biopsied. None of them had positive biopsies that were helpful, and 2 of the patients that had negative biopsies ended up having relapse. So, the utility of biopsy in this situation is also questioned. The other thing to add is that, the Indiana group has published on their experience in patients who had viable seminoma at the time of RPL&D. Now, this is 36 patients who had their surgery and then had viable seminoma, and the outcomes were actually pretty poor. In patients that at the time of surgery had viable disease, had 54% cancer-specific survival and 25% remained cancer-free. And their conclusions were that viable seminoma is particularly resistant to local control with many RP relapses. So one may ask, if all the patients that have viable disease that you take out end up relapsing, why are we doing the surgery? That being said, this study included a lot of patients that actually had this was a second RPL&D that had viable seminoma in it, and it also included patients that were having surgery after salvage chemo, so not after primary chemotherapy. And so this is a really, really, really high-risk group. One might argue this group may not even see the kind of representative patients that many of us see. So I think it's a little bit biased towards poor outcomes because of those things, but it is an interesting thing to note. And then the same group also published their experience with high-dose or salvage chemotherapy, and their outcomes look pretty good with the 2-year progression-free survival in 90% in 79 patients with relapsed or refractory seminoma. And so if you compare sort of the outcomes with salvage chemotherapy or high-dose chemotherapy compared to that with surgery, which is clearly not a direct comparison, one might wonder if we should be treating most of these patients with salvage chemo. So in summary, given the low rate of residual tumor in lesions greater than 3 centimeters, we really should not be using FDG PET in this setting. I think you can consider it in the tumors that are greater than 3 centimeters, especially if, they look like they would be surgical candidates if these were residual disease. If the PET scan is negative, that's also very reassuring. You need typical surveillance in that. If it's positive or equivocal, I would consider repeating it because a few patients end up clearing their PET positivity or their FDG avidity, and when they clear it, then those patients are very unlikely to relapse. And then, think hard about exactly who we should be doing post-chemotherapy surgery, and then consider salvage chemo at unequivocal progression or if the morbidity of surgery is really high. In the non-seminoma, so this is much less well studied, and that's just because it is much more difficult to sort of tell the difference between FDG PET avidity in viable germ cell tumor versus in teratoma. And so you can see, this is one example of a study, and probably the best one, that FDG PET is really only marginally better than conventional CT in assessment of residual disease for non-seminoma. So for example, this is 85 patients with a positive predictive value of 91 and 62%, and negative predictive value of 62%, compared with conventional imaging that's 84 and 58. So a little bit better, but very, very similar. And for this reason, we use sort of conventional CT. There's one study that looks at this kinetic rate of FDG avidity, but it's really not validated. And so because we can't tell the difference between residual teratoma versus scar, necrosis, et cetera, versus viable tumor, we really don't use FDG in the non-seminoma setting. And so most of the guidelines actually say, quote, it has no role in the management of non-seminomas post-chemotherapy. Now, to move on to some of the clinical trial work that's been done, the question is, okay, so if PET has such a good negative predictive value in seminoma, can we use it earlier in treatment to actually de-escalate chemotherapy? So this is the CME-TEP trial that was presented at GU ASCO 2 years ago. Essentially, they took a cohort of patients with good risk seminoma, gave them standard EP times 2, and then did a PET halfway through chemotherapy to look at response. If the PET was positive, they continued on standard of care chemotherapy with 2 more cycles of EP. If it was negative, they gave them carboplatin times 1. So essentially a de-escalation with a chemotherapy that is less toxic for patients with a negative PET scan halfway through chemo, given the good negative predictive value of PET. And these are the curves from the 2 arms. The patients that got EP times 4 are green. The ones that got de-escalated, which was actually the majority of patients, got EP times 2 and 1 dose of carboplatin. And you can see the 3-year progression-free survival is actually exactly the same in the 2 arms. One might argue, well, if the better risk patients, the ones that got de-escalated, had gotten EP times 4, maybe their curve would have been a little higher. But the outcomes are very good at 90%, so it's very hard to say that. But it looks pretty safe. And we know that, patients with seminoma that relapse end up being very curable with salvage chemotherapy. So I think this is really interesting. It is not yet, I think, considered standard of care. There has not been validation. It's a pretty small study, but it's, it bodes hope for de-escalation of chemotherapy. And then this is a similar study that actually treats all patients with carboplatin and similarly looks at the PET scan after 2 cycles of treatment. Actually, I think this is after 1 cycle of treatment. They give carbo, and then they determine how many future cycles of carboplatin they get based on whether the PET is positive or negative. Those with positive PETs get 3 cycles, those with negative PETs get 2 cycles, et cetera, et cetera. Carboplatin is not as standard for treatment of these patients in general, so I think this has been less intriguing or adopted in the community in general, but is also sort of a really interesting way. This is how we very commonly treat lymphoma, which is also very PET avid and chemo responsive. And then just a couple comments on the new tracers. We don't have quite the amount. It's hard enough to do testicular cancer studies with FDG PET, so there's not big, huge studies on the new tracers, at least not yet. There's a couple case reports looking at giving like 177 lutetium PSMA therapy for a patient that that had uptake on a gallium-68 PSMA scan. There was a mixed response, so it's not all that positive a case report, but is an interesting concept. And then similarly, we had a patient with testicular seminoma that had a case report that got picked up on a 18-choline PET done for prostate cancer. So, it is possible to pick up some of these cancers with other tracers, and I think it will be interesting prospectively to see what tracers are studied in testis cancer. And then this is a fluciclovine PET that is being investigated as a way to sort of differentiate necrosis from teratoma, which would be potentially very helpful in those post-chemotherapy non-seminoma patients. There was only 10 patients that were investigated and had a pretty poor sensitivity and specificity, so I'm not sure if it's moving forward, but that would be another sort of like the renal talk, looking at oncocytoma versus, picking up these teratomas would be actually very helpful clinically. So in conclusion, there's currently no role for PET in non-seminomas. FDG avidity has a high negative predictive value for post-chemotherapy residual seminoma, so very helpful in that standpoint if it's negative. Management of positive, greater than 3 centimeter seminomas after chemo is nuanced, and RPL&D and surveillance remain options. And then PET may be used to predict early treatment response and de-escalate chemo, but this remains investigational at this time. Thank you.
I learned a lot in that talk. It's not always good to see sometimes how your own imaging modalities don't work as well as you think they do, huh? Now, hopefully this works. How about that? It opened right up. Okay, well, we made it to the last talk. I apologize you have to listen to me before going and get coffee, but hopefully we'll keep you awake for the next 30 minutes. So I'm going to talk about PSMA PET. And hopefully by the end of this, we'll have a couple of questions on all of our talks, and then we'll get to a coffee break. So these are my disclosures. So prostate-specific membrane antigen is a transmembrane protein overexpressed on prostate cancer cells. I think everyone now is familiar with this term because it's been used quite a lot. Everyone should also know that it's not specific to prostate cancer. Other cancers like renal cell carcinoma also express PSMA, and that's obviously, as I'll talk about, expressed in a lot of other benign conditions. But in general, in patients who have prostate cancer, it's surprisingly specific and sensitive for the detection of metastatic disease. So this is the case I always like to show, right? Patients with low PSAs where we would never be able to localize disease. Now you can get a PSMA PET and localize osseous and soft tissue metastases. And I think when I first gave this talk, the first time we gave this was in person, I made some comment about I can't wait for the time when we can get rid of bone scans and CTs and get down to one imaging modality to stage patients. And we are now in that era, right? So now you can actually get a single PET imaging study with PSMA, and you have complete staging of patients with prostate cancer, which is quite nice. There are a lot of radiotracers out there, and this obviously causes a lot of confusion. So you can see many of these are FDA approved, some are in clinical trials. What's important to note is they all share this urea motif, right? And they bind to PSMA in the same way. So I think of all of these agents as a class. Okay, so they function very similarly, although as I'll show, there's some differences in biodistribution. PSMA 617, this is the agent in phase 3 trials. In the VISION trial, got FDA approved in March of this year, although Novartis can't deliver it to us right now, so we can't treat patients, but that's a separate issue. PSMA 11, we got this approved from UCSF and UCLA back in 2020, and actually there's now second NDAs from Telix Pharmaceuticals, and Novartis also got PSMA 11 approved as well. And then DCF-PYL, this is Pifluflolostat, or Pylarify. This got approved in December of last year. And this is the one that people are going to be most familiar with. It's going to be most widely available. It's fluorinated and some easily distributable, although PSMA 11 is becoming available around the country as gallium generators get installed to make this. PSMA 1007, this is in phase 3 clinical trials. This is RHPSMA 7 on the top right here, and this is also in phase 3 trials that actually have complete enrollment. Was presented at ASCO GU this year, and I'm sure there'll be follow-up data on this agent at ASCO in a couple weeks. The only other compound out there is CTT 1057. This has a different binding moiety, so it's actually a phosphoramidate moiety which binds to PSMA in a different way. It's an inhibitor rather than sort of an agonist, and it's also now entering phase 3 trials in the US as well. So you can see there's a lot of these agents. There's 2 FDA approved and more coming down the pike. I think about it in this way. So PSMA11 on the left here, DCF-PYL in the middle right. These I think of as nearly identical. Biodistributions are the same. If you look at the trial data, I'll show you, in essence, the same sensitivity and specificity in very similar populations. PSMA 1007 has this hepatobiliary excretion. You see the liver is very avid, not a lot of activity in the bladder. So the idea here is it might be better for looking for local recurrence, right, for seeing disease that's adjacent to the bladder. CTT has a different biodistribution, a little more blood pool, but also works well for localizing disease. Okay, so looking back, we used to use fluciclovine. Hopefully, we're getting past the era of using fluciclovine in prostate cancer. This was a paper by Jeremy Calais out of UCLA, and it showed that you had, in essence, nearly a double or more than doubling of detection sensitivity on a patient level. The percent of patients you localize disease was twice as high with PSMA11 compared to fluciclovine. This is in patients after radical prostatectomy with a PSA less than 2. So what we're trying to do here is see if salvage radiotherapy wouldn't be a good choice or if there's disease outside of the consensus tumor volume. Note, fluciclovine pretty much only saw disease in the prostate bed, right? But PSMA sees, in essence, lots of metastatic disease and pelvic nodes. This is the disease that's going to change management in these patients, right? And so this is why PSMA11 is markedly preferred. The other thing is interreader variability. It's much easier to read PSMA. Now, I'm going to show in a couple slides all these false negatives and false positives, and it is difficult, obviously, with any imaging study to interpret, but PSMA has a much higher interreader agreement than fluciclovine. 0.2 is actually really terrible. 0.67, this is consistent with most imaging studies. 1 is perfect agreement, 0 is perfect disagreement. Okay, another comment about agents. People always want to say one is better than the other. So this is a paper that I stopped presenting because I don't like the paper, but I think it highlights an important issue. So this was a patient who got DCF-PYL and PSMA11. This paper concluded in 15 patients that DCF-PYL was better than PSMA11. Okay? Now, on the left here, they gave 9.7 millicuries of DCF-PYL and imaged it at 120 minutes. In the PSMA11, they gave 1.7 millicuries and imaged at 60 minutes. Any radiotracer would beat itself when given this different activities and with different uptake times. So FDG would beat itself if you did this with it, right? And this is well below any administered activity you should ever give with PSMA. And so my point here is that scanner and acquisition protocols and activity use and uptake is way more important than the radiotracer you use. So it's this idea that we have to worry about this tracer versus that tracer, I'd like to nip that in the bud. And so in my mind, the best PSMA PET agent is the one the patient can get. Okay? So we want to use this. It's improving the staging of these patients. Don't worry about the differences between these radiopharmaceuticals. Okay, now I'll go to the false positives. I think it's important, particularly when you're seeing patients, you'll get a lot of these reports, and I will say that not all nuclear medicine physicians are comfortable yet with interpretation of PSMA PET, and so people will be calling things that generally I would consider a false positive. So rib lesions is the #1 issue, particularly patients at initial staging. You'll find these solitary rib metastases, and those are not going to be real. If you have a patient at initial staging, all they have is a single rib lesion, that's going to be benign. Okay, so just keep that in mind. Do not hold back potentially curative radical prostatectomy or definitive therapy because you see a rib lesion. Pre-sacral ganglia are also overcalled sometimes. These are anterior, posteriorly oriented just in front of the sacrum. These are also not real disease. Once you get familiar with this, you'll never call it, but I used to call this before it was described, 5 years ago when I was reading PSMA PETs, and now I obviously know better. Dorsal root ganglia, which we skipped over there, hemangiomas, Paget's disease here, classic appearance on CT. There is a characteristic appearance in Paget's, which is confusing. It's a cotton wool appearance. It looks like a sclerotic rounded lesion, which for all intents and purposes looks just like a MET. The second patient we ever imaged with PSMA back in 2015 had cotton wool Paget's disease, and no one had actually described Paget's disease having an uptake with PSMA PET, so we were scratching our heads for quite a while trying to figure out what that was. Other tumors, and particularly lung cancer, has uptake on PSMA PET. A lot of and they have really good uptake on PSMA PET. It doesn't look low level, so SUVs in the 10s. You can see here on the PSMA PET image, it looks very avid. But this one's obviously fairly straightforward. It's spiculated, doesn't look like a cannonball MET like you'd expect from prostate cancer. In this setting, you really want to keep in mind the patient history, right? So if you have a patient initial staging, they're not going to have lung mets, right? So if you're seeing something at that stage, you should obviously be thinking of lung cancer. If you have a patient with CRPC end stage, they're all post-dose Taxol or abiraterone, the chance of having lung metastasis in that setting is going to be much higher. But just remember, lung cancer in particular is going to be avid on PSMA PET, but many other cancers, RCC, hepatocellular carcinoma, thyroid cancer, et cetera. We just saw a case report of, gem seminoma, I can't remember what your case report was of, but everyone's trying this agent in many different cancers. Now, I don't like this term false positive. I want to change that term to true negatives. If we train ourselves to interpret these images well, we won't call these positives, and so they will actually just be not reported because they'll be normal uptake and we won't report them. So just keep that in mind. We think about this as a negative aspect of the study. It's just training for us nuclear medicine physicians to do a better job of interpretation. Now, the other things to think about in terms of interpretive pitfalls. So here's a case. You can see this is a T2 weighted image on a PET MRI. These are the ureters filled with urine, right? So they're T2 bright. This lesion here was actually originally called ureteral activity, right? Because it looks very close to the ureter, but you can actually see there's a little lymph node here right posterior to the ureter. And so when you do the fusion, you actually see the activity is just posterior to the ureter. So ureteral activity can both mimic cancer and mask cancer, right? So you have to be careful about ureteral activity, and this is one of the places I spend a lot of time when I'm interpreting images, just making sure what I know is ureter versus cancer. Sometimes on the anterior projection image, the ureters are linear and superior inferiorly oriented, whereas nodes are punctate, is one way to also tell, but you have to be careful about that. Another thing is this bladder activity. So we were hearing about FDG PET and bladder cancer, how the FDG will actually mask the primary tumor, right? Same thing can happen in essence with PSMA PET. You can see here there's uptake in the bladder. Now obviously the CT is acquired at a different time than the PET, so you don't see the full bladder on the CT scan, but it fills up with this radioactivity during imaging. And you can see just this little nodular uptake right at the base of the bladder that correlates with these little enhancing nodules. When you're looking at the bladder, you want to look for the wall being not linear and flat. And if you're seeing that, that should really raise your suspicion for there being local recurrence. Sometimes these aren't as clinically relevant because you're going to be irradiating this area anyway. Sometimes they can be very clinically relevant. So you can also do delayed imaging. At our site, we don't give Lasix anymore or do delayed imaging, but many sites around the world will do that. Okay, now I'm going to talk about clinical indications, and we're going to go through sort of the appropriate use criteria, which we spent a lot of time making for PSMA PET, and I find this document helpful to follow through because obviously I wrote it, therefore I think it's really awesome. But no, I think it's helpful to think about it in the way this document is. So the initial staging indications. So we listed 5 different indications for initial staging. And in this setting, there's different areas. So remember, when you think about appropriate use, this is actually important when you order high-end imaging studies in the future, which starts January of next year. You will have to use a decision support tool software to actually get reimbursed by Medicare for these things. So these AUCs are actually going to be pretty important in order for you to actually get your imaging studies done. We obviously, for scenario 3 and 4, these are the indications that are approved. So you have to be a score 7 or above to be covered by Medicare. So anything 7 above is called indicated. Anything below is in essence not indicated. But these would be patients with unfavorable intermediate high risk or very high risk prostate cancer or having oligometastatic disease on CT. This is in essence matches Nccn Guidelines. The only weirdness here is scenario 5, this newly diagnosed prostate cancer with widespread mets on conventional imaging. That's a little unusual because there's this weird thing now where people are actually getting CTs and bone scans still, and then you're trying to decide if you want to get a PSMA PET once you've already had a CT and bone scan. In a year, presumably no one will get CT and bone scans anymore, and so this isn't a relevant indication, but there's sort of an overlap time where you might have patients who have frank mets, and obviously if you have frank mets, there's going to be no clinical benefit of getting a PSMA PET. And then in patients with very low, lower, favorable intermediate risk, it's not appropriate. All the clinical data to date is in patients who have high risk or intermediate risk prostate cancer. And then looking for patients who don't yet have a pathologic diagnosis, obviously it's not indicated. These are the papers really that support the initial staging indication. So our paper out of UCSF and UCLA using gallium PSMA-11, and then the OSPREY trial with DCF-PYL. Very similar studies, surprisingly similar patient numbers, very similar sensitivities and specificities. In essence, these agents behaved nearly identically. What's interesting is these sensitivities were lower than we actually had anticipated. When you looked in the literature back in the day, the sensitivities biopsies were, in the 65, 70% for nodal metastases. And what we're missing are these 3 millimeter pelvic nodes. They're just really hard to see on imaging studies. It's not that surprising. But in essence, this is the data that supports that. There's also the Pro-PSMA study. This is a randomized trial out of Australia where they took men with initial staging and randomized them to get either CT bone scan or PSMA PET up front and then crossed over to see how CT and bone scan compared to each other. The take-home point here is that this bottom bullet point, 31% of patients had a change in management with PSMA PET compared to 23%. But the weird thing about this study is they reported this 85% sensitivity for PSMA PET, which at first was a head scratcher because we were getting 40% with PSMA 11 and DCF-PYL. And then when you look a lot more closely, you realize that only 4 to 5% of patients actually had pelvic nodes confirmed at histopathology. What they're talking about is, in essence, a sensitivity for METs that you see on conventional imaging outside of the pelvis, right? Bone scans and big nodes. And obviously in that setting, you have a much higher sensitivity because you're, in essence, confirming it with conventional imaging. So it's sort of a weird biased sensitivity. So this isn't as if it has like a better sensitivity than the other. It's just, I think of them as complementary. This is more talking about distant METs, whereas the other two trials I just showed you were talking about pelvic METs with path correlation. So the specificity is much more important on the other papers that I was talking about. I think the most important aspect of PSMA PET is actually on radiation therapy plane. I think our radiation oncologists really love PSMA PET because they now have things to zap. So this is an impact of high-risk patients at initial staging. We took 45 patients, looked at where the PSMA PET avid disease was, and found that, in essence, 53% of the patients we imaged at initial staging who had high-risk prostate cancer had to change to the radiation therapy plans based on the results of the PSMA PET. That's actually pretty impressive, how impactful this is on radiation therapy planning. Now, in terms of initial staging, the other thing that's interesting is that there are patients who have, in essence, PSMA negative disease, right? It's not that common, but it does exist. So if you look at our trial, the PSMA 11 paper that I said in JAMA Oncology, and look at the sensitivity based on the uptake in the primary tumor, not surprisingly, as your uptake in the primary tumor goes up, the sensitivity for disease goes up, right? So if your uptake is less than or equal to blood pool, the sensitivity is only 25%, and if it's greater than PRODS, it goes up to 47%, right? So the sensitivity is directly related to how avid the primary tumor is. That's not too surprising. So in this patient here, very low uptake. You look on the MIP and it doesn't really look that different than blood pool. You can see here this patient clearly has a nodal metastasis greater than 1 centimeter in short axis, but just has very low avidity, maybe just a hint, a whiff of PSMA avidity. But you can see how the expression of PSMA in these tumors can impact the sensitivity of the study. Okay, so just keep that in mind, and you just look down at the prostate, see how avid that primary tumor is, and that will help you understand the sensitivity for nodal metastasis in that individual patient. Now, as I said, there's PSMA negative tumors. So here's a patient, this is a high B-value DWI image. ADC is dark, restricting on diffusion. Here's a CT scan, not that useful. PSMA PET, you actually see uptake maybe on the other side of the prostate, but really it's frankly negative, so no evidence of activity in the prostate. Now, I want to make a point about PSMA negative tumors because I think there's a bit of confusion with this. So first of all, people think of PSMA negative tumors as bad actors. Okay? If you have a PSMA negative tumor, that's bad. So, and that comes from data like this. So this is patients who were being screened for PSMA radioligand therapy, and they looked at what happened to patients who had PSMA negative tumors in those patient populations. And the overall survival in those patients was 2.5 months. So a PSMA negative tumor in the end stage CRPC setting after docetaxel is terrible, right? That in essence, there's no effective therapy. You should go on hospice really if you have a PSMA negative tumor in that setting, okay? But the opposite is true in initial staging, right? So this is the primary trial, which is actually a really cool trial about Australia by Louise Emmett. I think she won like Paper of the Year from European Urology last year. I'm not really sure. And so the x-axis here is SUV max, and the y-axis is PIRAD. So the lower your PIRAD score, the lower your SUV max, right? So the lower uptake, less likely to have aggressive tumors. And then I've just put in this slide here the primary score. They're actually running primary 2, where they're now going to take patients and do PSMA PETs and pre-biopsies, sort of like MR-guided biopsies, but doing PSMA PET-guided biopsies and see if PSMA PET outperforms MRI for the localization of primary tumors. And I think they've already enrolled like 40 patients in that trial, so that'll be very exciting as well. But my point here is that at initial staging, low expression is actually a good thing, and I'll show another slide in a minute later on the biochemical recurrence setting talking about that. So, biochemical recurrence indications, this is obviously the slam dunk setting of PSMA PET, right? If you have biochemical recurrence with a persistent or rising PSA after radical prostatectomy or after definitive radiotherapy, this is clearly the best imaging modality to stage those patients. We did not approve PSA rise after focal therapy of the primary tumor for a couple of reasons. One, the idea here was that this would actually sort of go back into the primary indication setting. So if you have a Gleason 4+5 tumor, you should be staged as if you're being initially staged. And secondly, it's unclear what PSA is for recurrence, defines biochemical recurrence after focal therapy as well. So we struggled with this was sort of a debatable topic, although I saw on the AUA agenda there was some discussion about how RT and RP are no longer the only approved ways to have definitive therapy for prostate cancer, which I found surprising in a urologic association meeting. But anyways, apparently times change as well, not just in imaging. So the biochemical recurrence studies are, again, UCSF, UCLA, PSMA 11, and Condor study with DCF, PYL. Similar studies as well. We imaged a heck of a lot more patients, but had not as many patients who met our composite endpoint because our composite endpoint required either imaging correlates or follow-up, et cetera. The company-sponsored trial, probably because it was paid for, had a much better follow-up, so they had 208 patients total with 132 that met the standard of truth. And the detection rates you can see here based on PSA are very similar. The correct localization rates or positive predictive values are very similar. Again, just like the initial staging, these two imaging agents function nearly identically and should be thought of as interchangeable. Obviously, PSMA PET has a huge impact on the management of patients, right? And so this is just showing that in patients who, in essence, have a negative PSMA PET, patients had a trend towards surveillance. If they had nodal disease, they had a trend towards radiation therapy or targeted therapy. If they had metastatic disease, there was a trend towards systemic therapy. This is all fairly obvious. I do have some issue with this surveillance data, and I'll show you some slides on that in a couple slides about why hopefully we don't surveil patients with PSMA negative disease. Now, here again showing a patient after radical prostatectomy PSA rise from 0.5 to 0.9. Now, this case I like. This is one of our earliest cases. This patient then got metastasis-directed therapy to those two nodes and has been actually biochemically free since then, which is pretty impressive. Why I think it's important is you look at these nodes and they are hot, right? You don't need a nuclear medicine physician to interpret this image for you. Anyone can look at this and say, okay, that's prostate cancer. In that setting, I'm much more confident I'm seeing the entire extent of disease, so metastasis-directed therapy is likely to be more effective. The patients who have low-level expression, low uptake, we're probably missing smaller nodes elsewhere. Maybe there's more disease that we're not understanding. But with these population of patients who have really avid disease, we're probably seeing the entire extent of their disease, so metastasis-directed therapy is going to be more effective. That has not been proven in any respect, but just anecdotally, I see that. And then I hopefully, for some of the trials that are recruiting now, we can retrospectively analyze that to see if that's true. STOMP, I think you're all familiar with this. This is a choline-based metastasis-directed trial showing that MDT outperforms surveillance in terms of ADT-free survival. There's also Empire 1, very similar study. This is in a patient population post-radical prostatectomy, PSA less than 2, fluciclovine versus conventional imaging, showing improved biochemical-free survival when using fluciclovine for planning the radiation therapy. Now, this hasn't yet been done with PSMA, but it's enrolling. So this is done enrolling. Jeremy is running a trial here of PSMA PET randomized, or patients randomized to get PSMA PET versus conventional imaging, and this will hopefully read out like Empire 1, showing that patients will have improved biochemical-free survival when you plan your radiation therapy with PSMA PET. I think fairly straightforward, the idea here, as your PSA goes up, your detection rate goes up. Right? So the higher your PSA is, the more likely you are to see disease. But there's always this question of when should I get a PSMA PET, right? What PSA should I use to trigger my PSMA PET? And I sort of want to say in general, don't wait for a higher PSA to get a positive PSMA PET, right? In essence, let's wait for our patient to get metastatic disease before we try to look for metastatic disease, right? And it's probably the wrong way to think about this, but a lot of people will do this and say, oh, I need to get a PSA of 0.5 because I want to have a PSMA PET PET that's positive. And let me show you why that's probably not a good idea. So this is Louise Emmett, the woman who ran Primary 1, also did a retrospective analysis out of St. Vincent's, Sydney, and it was really nice. So here you can see these two bars in this chart are people who have a negative PSMA PET or local disease, and after they're treated with salvage radiotherapy, those patients do really well, right? And that is independent of PSA level. Okay, so you can see, independent of PSA level, the patients who have only local disease do really well. Does that make sense? So you want, if you, as a patient, you want a negative PSMA PET, right? That's what you want. If you undergo radical prostatectomy and your PSA is 0.2 and you have a negative PSMA PET, awesome. Get your salvage radiotherapy and you're going to do great. Do not wait for the patient to get pelvic nodal metastases on PSMA PET to treat them with or salvage radiotherapy. Okay, so I think that's a really important point, and a lot of people sort of misinterpret that. Okay, the CRPC settings, the last area I'll talk about. So in the non-metastatic CRPC, we actually approved it as being indicated, and this is sort of interesting because in M0 CRPC, there's actually becoming more data that you can treat that disease with oligometastatic directed RT. Not totally standard of care, but we're moving towards that. And so in this M0 setting, there's potentially a clinical role for PSMA PET. But in patients who have, for example, a post-treatment rise in the metastatic setting, who aren't being considered for PSMA radioligand therapy, there's no clinical role for localizing that disease, so it's not appropriate. If you're being evaluated for lutetium-177 PSMA-617 therapy, then obviously this would be very appropriate, and so that should be indicated. And then right now, for evaluation of response to therapy, this is not indicated. So really only in the MCRPC setting, if you're being considered for PSMA RLT, or in the M0 CRPC setting, would this be indicated. This is the data in patients with M0 CRPC. We looked at 200 patients who had M0 CRPC. 98% of them had positive PSMA PETs, and 40% of those had oligometastatic disease that could be targeted using RT. So there's actually a large percent of these patients, and actually UCSF are running a trial called PILLAR, where we're taking M0 CRPC and randomizing them to get apalutamide versus apalutamide plus RT to see if the addition of oligometastatic directed RT will actually improve outcome in patients. Now, what about selecting patients for PSMA RLT? So here's a patient, PSMA PET, you have your parotid, has an SV max of 15, the tumor's 31, the liver's 4. This patient clearly meets criteria for PSMA RLT, and you can see that the PSMA PET, in essence, predicts the uptake on subsequent doses, right? So this is the post-cycle 1 image. This is done with a SPECT scanner, right? So you can have a planar image done on a SPECT scanner, and you can see the response over time. And so PSMA PET should definitely be used to select patients. One of the issues is that the therapy trial, which I'm not going to go into this too much, used an SUV max cutoff. The VISION trial, the one that led to FDA approval in the US, had uptake greater than liver. And so this uptake greater than liver is a really important point because physiologic uptake in the liver matters. So Pluvicto, it actually, interestingly, in the package insert, this is lutetium-177 PSMA-617. I try not to say vipivotide, but anyways, it's obviously indicated for treatment of MCRPC, but it says in the package insert to select patients using Locomets or a PSMA-11 imaging agent. Okay, so it actually, in Locomets, I don't know how they got their brand name in there, is just PSMA-11. So in essence, the package insert for Pluvicto says you have to use PSMA-11 to select patients, and I think we don't believe that. So do you have to use PSMA-11? No. So here is a paper which compared DCF-PYL versus PSMA-11, and you can see that over here in the liver, there's in essence identical uptake in the liver with both PSMA-11 and DCF-PYL. And so the selection of patients here would be in essence identical with both of these two agents. And given that PSMA-11 is not widely available in the United States, we really do want to allow patients to have patient selection with DCF-PYL so that patients can get this treatment easily around the country. Now, NCCN guidelines are in essence identical. So initial staging is in unfavorable, intermediate, high, and very high-risk patients. Biochemical recurrence, same as us, no PSA cutoff provided. And then do include actually progression for CSPC systemic therapy, including patients with castration-resistant disease. So this is sort of like the M0 CRPC, but they add in the M0 CRPC as well. Okay, so that's NCCN guidelines. I do like the fact, the phrasing in the NCCN here about conventional imaging, I like the way they put it. So the panel does not feel that conventional imaging is a necessary prerequisite to PSMA PET, and PSMA can serve as an equally effective, if not more effective, frontline imaging tool for these patients, right? So this, you will get pushback from insurance companies who want you to get a CT and bone scan prior to getting a PSMA PET. That's why this verbiage was put in the NCCN guidelines to say, hey, do not get CT and bone scan prior to getting a PSMA PET. Nonetheless, I'm sure we will still be fighting for insurance companies for another 6 years, but that is what it is. So in summary, 1, there are now 5 approved MDAs for PSMA PET, right? So we have 4 for PSMA 11, and then we have 1 for GCF-PYL. PSMA PET should be used in unfavorable, intermediate, high, and very high risk patients at initial staging, at time of biochemical recurrence after radical prostatectomy and radiation therapy, in the non-metastatic CRPC setting, and to select patients for PSMA radioligand therapy. And then I think the point I've made about 12 times in this talk, PSMA 11 and DCF-PYL should be considered equivalent clinically, so whatever agent you can get access for your patient is the one that you should use. So thank you very much, and I think we have now time for questions.
Wonderful. Thank you all to our panelists for presenting today, and we're happy to take any questions that the audience may have.
Good morning. Excellent talk. Thank you. For the PSMA scan, does renal function, does it affect the scan?
No. Sometimes Kurt's not the best way to go.
Tom, are you doing PSMA CT? Or are you doing PSMA MRI?
So probably not relevant to most people in this audience, but we at UCSF have a PET MRI, which is a very cool modality that has obviously an MR and PET scanner that's integrated into itself, so you get both PET and MRI images simultaneously. Half of all of our PSMA PETs are done on our PET MRI. Mainly just scanner availability, because with PSMA 11, it's a gallium-labeled compound made with a generator, so you can only make 2 doses at a time, and they have to be given, in essence, at the same time, so we put the patients on one patient on one scanner and one on the other and image them. But I think for initial staging patients, I find the PET MRI helpful. For early biochemical recurrence, it's helpful because the DCE MRI, the contrast-enhanced MRI in the prostate bed, is helpful for visualizing that local recurrence and the anatomic correlate to what you see on the PSMA PET. And actually, I'm finding, surprisingly, in the CRPC setting for PSMA radioligand therapy, it being very helpful because we're starting to do whole-body diffusion to look for PSMA negative disease, in essence, as a replacement of FDG. That's sort of an interesting way to think about it.
Tom, for those who don't have access to a PET MRI scanner, do you find that cross-modality fusion is accurate enough to allow for you to fuse it up to an MR?
Yeah, I don't know about I like that, to fuse it up to an MR. You know,
I'm sorry to say that.
yeah, no, absolutely. You could get an MR, a DC MR with contrast, it totally works just fine. Actually works great. And you don't need even to fuse them, right? I mean, you can, we cognitively fuse them, right? Without actually trying to overlap them, and it works just fine.
I was blown away by that ureter case. That's more what I had in mind.
Oh yeah, that I think is, that one, I think the CT is fine. You don't need an MR for the ureteral case. The benefit of the MRI is for DCE, looking for local recurrence, seminal vesicle involvement, adjacent to the bladder, looking for little enhancing nodules. That's where really MRI shines. The ureteral case is a cute one, but you don't need the MRI for that. CT would be just fine for showing that distinction as well.
Yeah, we've put a lot of effort into attempting to, do what described, actually, fusing them, and it never, despite the best, the deformation technology that we have, it just never quite looks as good as those PET MRIs do.
I agree, my images look the best.
Well, thank you again for attending, and I think there'll be some follow-up questions that come to you based off of these presentations today, just to evaluate the course, and welcome back to in-person. Have a good day.